people suffering from hearing loss, balance issues, and infectious debris earwax from the ear canal. This is a very interesting case. I don't think this is one for some of those armchair critics. This client attended A&E on Sunday. He had a wax buildup and he used a tissue to try and remove that, and all he achieved in doing was to force this wax and dry skin directly onto his eardrum. A&E are not involved in earwax removal, and he, prior to finding myself, he saw another specialist who said they just simply couldn't help because the wax obviously was on the eardrum, and a lot of the clinical ear care specialists wouldn't attempt to remove wax off the eardrum. I'm sorry about the lag here. Again, I'm not sure why this is happening, but it's happened on a few videos, and I hope it's not causing anyone inconvenience. So prior to me performing the procedure, I showed you a pre-examination video, and that wax and dry skin was extremely hard and dry. You could compare it to chewing gum that's on a pavement, that's on a warm day, it's literally stuck to the pavement. And similar scenario, we've got this dryish but yet sticky wax and dead skin directly onto the eardrum, and this was causing him a significant hearing loss. I did a middle ear pressure test prior to starting. It's a test called tympanometry, and we assess how well the eardrum and the three tiny bones called the ossicles are vibrating essentially, and there was no vibration whatsoever prior to the procedure. Knowing that the wax was very hard and it was impacted directly and adhered onto the eardrum, prior to commencing the procedure, I instilled some sodium bicarbonate earwax drops to try and loosen this, and I also then used some olive oil drops too. So the suction probe you see on screen, it's not the standard Zollner suction probe. I've attached a fine end gauge. A fine end gauge is a narrower extension of the standard Zollner suction probe, and it's designed for delicate procedures, more namely near the eardrum. It's less atraumatic, so if we do come in contact with the eardrum, it's less likely to perforate it. It's not to say that it won't perforate it if you're not delicate, and that's why this procedure is so complex and delicate, because one false move, we could puncture his eardrum and cause more issues. And also a fine end gauge has less suction noise, so when we go closer to the eardrum, obviously the noise from the suction probe becomes more intense, and it can be quite deafening for the client. You can see the view we're getting there, and this is one of the benefits of the iClearScope, the wireless endoscope that I developed alongside my colleagues at Clearwax. And I should give a shout out to my fellow directors, Mr. Darius Rajali, who's a consultant ENT surgeon, and Mr. Shiraz Mohammed, who is also, like myself, a consultant audiologist. You can see here we're on the inferior posterior quadrant, and I was just trying to loosen that wax, and you can actually see the eardrum tug as well. You can see that movement if you look carefully. It is a real struggle. Just imagine peeling off sticky, dry, but yet sticky chewing gum on a hot day, or off your shoe, or off the pavement. It's not easy at all. I make no apologies for the length of this procedure, and because it is complex, it's not something that you can just go in with. I've read comments in the past about dry mopping, and I thought it's a good opportunity to me to address that. Dry mopping is when you attach a piece of cotton wool onto the serrated end of a Jobson horn. And the concept of dry mopping is to go in with the cotton wool and spin it, and as you're spinning it, you kind of mop up, hence the name dry mopping. You mop up wet debris. I've read a couple of comments, and probably a few unfair comments. Why don't you do dry mopping, and you should have done it on this case and that case. In the UK, dry mopping has really fallen out of favour, and that's because a lot of clinical ear care specialists now have adopted suction. I'm aware that it's still quite common in America. However, I should add, in America, it's still very common to use a metal syringe. I was gobsmacked when I attended the American Academy of Audiology conference in America a few years ago, and they were selling these metal syringes, and in the UK these are banned. They have been banned for a while. But in America, I'm not sure if it's in all states, but I think we were in Texas and they were actively selling this device, and I was shocked. So the point I'm trying to make is you can skin a cat in different ways. I'm not recommending you skin a cat, but you know what I mean. So different countries, different cultures have different methods of earwax removal, and I think there needs to be acknowledgement and respect of that. I was also asked why don't you use dry mopping to remove hairs, and I was also accused of the fact that hairs, I'm fully aware that hairs in the ear can cause problems. Well, I don't agree with that at all, because I've got loose hairs in my ears and I was blissfully unaware of the fact until I looked inside my own ears. And also with dry mopping, it's fine when you're doing it kind of external up to the lateral part of the ear canal and the midpoint, but when you go really deep, and again I've stressed this in quite a few of my videos, when you approach the isthmus, which is kind of about 5 millimeters away from the eardrum, and even more of the ear canal than that, the inner 2/3, sorry, where it's skin on bone, it's so sensitive. I'm not asking anyone at all, and I obviously advise not to anyone do this, but if you put a cotton bud deep in your ear and spin it, it is very uncomfortable. Apparently, for some people, when they do it, it's not uncomfortable from some of the comments I've been reading. But believe you me, if you go really deep, especially into the isthmus area, which is really close to the eardrum, it can be very uncomfortable. In any case, I'm just going to go back to the procedure. I am sorry about that, but there's a couple of things I wanted to address and clarify. So you can now see the eardrum, it is revealed there. There is still some dry wax and dead skin, but the client's symptoms had resolved at this stage. You may have noticed I did instill some more drops as well to further loosen this. I've just gone back in again to see if I can get a bit more off, but this is why I said some armchair critics won't like this video, because I didn't manage to remove all that. And I'm quite comfortable in admitting that, and I think clinically that was the right thing to do, because as a clinical earwax removal specialist, our job role is to alleviate and improve symptoms associated with impacted wax and dead skin. And this client at this stage already was. He was fine, he was able to hear, and actually post-procedure I repeated the pressure test I referred to before, core tympanometry, and his eardrum is now fully mobile. I did advise this client prior to leaving that if you did want me to remove this remaining piece of dead skin and wax directly off his eardrum, I'd be happy to do that, and also actually at no cost, but I would require him to use drops for a few days to further soften this. In reality now, or because of because this layer of dead wax and skin has been almost defragmented, I've removed a lot of it. This should now naturally migrate. I read someone's thesis on the anatomy of the eardrum, and they were interested at the rate of the skin shedding off the eardrum and migrating out of the ear canal, because the ear canal itself is a natural conveyor belt. It secretes wax, and this wax naturally migrates outwards. And part of that thesis, someone made a mark on the eardrum using a black permanent marker, and they followed up this individual, I believe in a weekly intervals, and I think after a month, this black dot that was made onto the eardrum had migrated. So that skin that had the marker on top has shed and migrated, and it was now visible midpoint of the canal. So similarly, in the first ear, I'm hoping now that skin will now naturally migrate, and I have encouraged him to use drops to help, but his symptoms have completely cleared. Now moving on to the second ear, the right ear, and the wax again is very dry. Fortunately, on this occasion, it wasn't stuck onto the eardrum. He wasn't using a tissue, pushing this further in. And there is some wax actually very adjacent to the eardrum, but I don't believe it's impacted. I'm just using again a fine end gauge, piece by piece. I'm just peeling this off the superior part, so the top part of the ear canal. You can see the skin adhesions there, and it's just gently wriggling that. And that hopefully will come out in a big piece. Let's see. Yeah, there we are. Again, at this stage, the eardrum's fully visible. Bit of dry skin, inferiorly to the eardrum. I believe I did go back and get that, so we'll wait and see. A lot of this procedure was performed a couple of days ago, so I'm narrating as I'm rewatching it. So let's see if I'm correct, and I went back for that. I'm not, oh, there we are. Yes. And again, for me, these procedures really get my adrenaline pumping because these are the complex ones. This is where you need a really steady hand. One false move, and I reiterate what I said earlier, can put me in a lot of trouble and also the patient in terms of their hearing. The last thing we want to do is perforate that eardrum. And when we go that close, there's always a risk, albeit the patient moving or my hand becoming unsteady. We do adopt a brace, so the brace itself accommodates for any sudden movements by the patient. So in that respect, we are trying to make this as safe as procedure as possible. And remember, these patients are awake. We don't anaesthetise them, general anaesthetic, and you'll see a lovely final view there of the eardrum. This is the wax that I extracted. I believe the majority of this wax is from the right ear. I hope you enjoyed that video. I got a feeling I'm going to get a few negative comments because of the first ear. There's some remaining bits of wax there, but these are the procedures I really, really enjoy. It really tests your skill and ability as a clinical